Thank you. Today is our last PPCL Perinatal Mental Health Tele-Echo. We're so happy everybody joined us today. This is our agenda. We'll do our best to stick to it. Sorry that the format got knocked off a little bit there, but we're going to do brief introductions. And Dr. Rainey Bruno will present our didactic, and Danielle Mistretta will do our case presentation. Danielle, did I say your last name right? Mistretta? Okay, thank you. Dr. Olivia will then lead us through some the case presentations, any clarifying questions, recommendations, and then we'll have some announcements at the very end. So just some brief introductions. I am Jody West. I am the program manager for the provider to provider consultation line. And for the ECHO, that's one of the services or resources that PPCL provides. We do 2 monthly tele-echo sessions about perinatal mental health and another one on pediatric mental health. This is the last session of this year, but we will be starting a new round in February. So we'll send out information about that as it gets planned. But if you want to scan this QR code, it brings you to our registration page. We provide mental health consultation across the state at no charge. So if you have any situations that you want to talk about mental health support, we have social workers that can assist you with resources, referrals, and any type of treatment and therapy. But then we also have access to psychiatrists who can walk you through diagnosis, additional therapies, as well as medication management if that's something you're interested. So that's our phone number, that's our QR code to get more information. And I'm going to turn it over to Dr. Olivier to lead us through some more introductions.
Hey, good morning, everybody, or afternoon, everybody, and thank you for joining us for our last perinatal echo. I know it's a holiday week, so we really appreciate your time. Again, I'm Dr. Olivier. I'm the facilitator for this session, so I'll be trying to make sure we run on time. I am a psychiatrist here in Lafayette, Louisiana at Bloom Mental Wellness, and one of the psychiatrists on the hub team. I'll go ahead and ask Dr. Finelli to introduce herself since she's the other psychiatrist on the team.
Thanks, Dr. Olivier. Hi, I'm Juliana Finelli. I'm a general psychiatrist and child psychiatrist, and I get to work with PPCL as a perinatal psychiatric consultant.
Thank you. And Dr. Zena, I saw you. Want to introduce yourself?
Yeah, hello, everybody. I'm Dr. Paula Zena. I am a pediatric nurse and also a pediatric clinical psychologist at Tulane. I serve as a nursing consultant for the hub team, and I'm excited about today's presentation.
Thank you, Dr. Zena. And Katie Abear, go ahead and introduce yourself.
Hey, y'all, I'm Katie Abear. I am a licensed clinical social worker, and I'm also perinatal certified. I work in private practice where I see perinatal clients at Bloom Mental Wellness as well.
All right. And also y'all met Jody already, who is our program coordinator and gets all this together for us. So for about the next 20 minutes, I'm going to ask Dr. Rainey Bruno to go ahead and present her didactic. She's presenting on bipolar disorder today. So just go ahead and take away, and just remember to tell us to advance the slides when you're ready.
Will do. Thank you so much. And what an honor and a privilege to be with all of you. I appreciate the opportunity to talk about this very important topic. I'm going to jump in because we just have 20 minutes and it's a pretty big topic to talk about. The perinatal period is a well-known vulnerable time for the new onset of bipolar illness, as most of us know, or for the reemergence of symptoms, especially bipolar depression. It's significant to know that women in particular, even non-pregnant women with bipolar illness, are more likely to have depressive episodes, rapid cycling, and mixed states as part of this chronic and remitting and relapsing illness. It's also significant to note that in pregnancy, depressive and mixed states can be more common, as well as in the postpartum, although in the postpartum states, they can be mixed, depressive, or manic with associated psychosis. Many cases of postpartum psychosis are new onset or exacerbation of bipolar illness. And of course, I really believe that this audience in particular knows that postpartum psychosis has a high risk of suicide and infanticide. All of that to say that the goal in terms of treatment of bipolar symptoms is prevention. And what a delightful word in psychiatry, right? There aren't many times in which we can talk about prevention. But prevention, not only in the peripartum, but I'd say extend that to adequate treatment for any woman or any one person with bipolar illness. particularly women of childbearing age, we would have always as the goal as a prevention of acute exacerbation through maintenance treatment, primarily pharmacotherapy, psychoeducation, and support, which is really the hallmark in perinatal psychiatry. So pregnancy is not protective from bipolar illness, onset or exacerbation or recurrence. It's been shown that in women who have discontinued medicine, especially discontinuing their mood stabilizers, that the rate of recurrence in the form of depressive symptoms is about 71%, pretty high in the first trimester. Women with bipolar illness have a greater risk of mood worsening immediately postpartum, especially within the first 3 days to 2 weeks. And women with bipolar disorder were 50% more likely than women with major depressive disorder to have postpartum depression. So although all of this may sound daunting, the great news is that we have ample evidence-based guidelines and data in the area of screening, treatment, and even prophylaxis to achieve that goal of prevention. And of course, it's best accomplished through planning preconception, or if there's not been the opportunity to plan, to have familiarity with evidence-based pharmacotherapy interventions, because that often requires that we are aggressive early on so as not to interfere with maternal and newborn well-being, nor to disrupt bonding and attachment. If we focus on that ample evidence on this slide under screening, I'd like to tell you about one study in particular. We have two that support this, but one in particular by Wisner and colleagues that included screening 10,000 postpartum women with the EPDS. And they found that when women had an EPDS greater than 10 and they followed it with a structured clinical interview, that 23% of those women met criteria for bipolar disorder. And then they followed it by giving the MDQ, or the mood disorder questionnaire. And the mood disorder questionnaire was able to predict or identify 50% of those with bipolar illness. And using the MDQ section on impairment criteria, increased that to 68%. So ideally, peripartum or preconception screening should not just be the EPDS or the PHQ-9. We should now add the MDQ, or we should have been adding the MDQ as a standard of care. And I've also listed here something called the Rapid Mood Screener and Bipolar Spectrum Scale, because on the Marseille Perinatal Mental Health a listserv, I don't know if you were any of you are on that, but I hope that you would consider joining if you're not. There was a recent discussion that not just using the MDQ, but in clinical practice, many are using the Rapid Mood Screener. And it influenced me to access it. It's much easier. It's only 6 questions, very focused, and it can be used in primary care settings like OB and pediatrics. And the bipolar spectrum scale is longer. It could be reserved for more like psychiatric settings. So now we're going to go back to treatment and planning. And I expected this, the next slide, please. Next slide. Okay, yeah. I expected this audience also knows all too well that the choice to continue medicines during pregnancy is a balance with the risk of untreated illness, of bipolar disorder, to the risks of medicine. And I think what's important to know is that bipolar disorder is associated with poor outcomes independent of medication exposure, such things as premature birth, intrauterine growth retardation, and neurodevelopmental struggles or delays. So in the preconception or early pregnancy assessment, it's important to inquire about the things that tip the balance in decision making. And I feel like as part of this discussion, it's important to highlight some of those. So if we're looking at making an informed decision about medication versus the risk of untreated illness, we have to inquire about hospitalizations, suicide attempts, psychotic episodes, and whether in those episodes she engages in high-risk behaviors, the areas that include substance misuse, smoking, high-risk sexual behaviors, and even spending, because that can lead to so many psychosocial stressors. So we know, hands down, some pearls I like to throw out in these short talks is that we know that abrupt discontinuation of medicine anytime in psychiatry never ends well. It eliminates that thoughtful consideration that's listed on this slide as number 1, And what happens is when bipolar illness, women with bipolar illness have abrupt discontinuation of medication in the peripartum, they not only have recurrence of illness, they have a longer time to recovery to get well if it's abruptly discontinued, which can really be problematic. It's an important clinical pearl in practice is also to know that if a woman is doing well on maintenance medication, it's important to take time for thoughtful decision making, to access risk benefit resources and apply her specific history, as well as involve specialists considering this a high risk pregnancy, specialists such as MFM, and of course involving mental health and OB before making any changes. And, you know, it's beyond the scope of this 20-minute presentation to get into the details of pharmacotherapy, but, oh, next slide, please. But pharmacotherapy is the mainstay of treatment for bipolar disorder in the peripartum. So what I like to do is refer you to the, you don't have to go to this slide, but to the references, because there are two articles in particular that give you beautiful clinical guidelines. And one is the Clark and Wisner article about titled Bipolar Illness in the Peripartum. And the other one is Lauren Osborne's article on postpartum psychosis treatment guidelines for the obstetrician. And she gives really good clinical vignettes related to things such as depression with psychosis, mixed states with psychosis, and mania with psychosis. And that's really what we want in the world of clinical practice, not just kind of numbers and statistical data, but clinical guidelines. So to just focus briefly, lithium and anti-seizure medications, specifically lamotrigine or Lamictal and carbamazepine or Tegretol, as well as the second-generation antipsychotics, have the FDA indication for treatment in bipolar illness. So these are the ones that we look at in consideration. And just in short, because boy, time goes by fast, I'm going to not mention them specifically, but say that the atypical antipsychotics, the ones that are older, are the ones we always have more evidence base for. And so when we look at those, we look at, in particular, olanzapine, Seroquel, and Abilify as being relatively safe. But what's important to mention here, especially in marginalized populations or in Medicaid served populations, for the longest time, Depakote was one of the only mood stabilizers on the formulary, and Risperdal. And those were given to women of childbearing age often, but now it is frowned upon and discouraged as a standard of care because Depakote, of all the anti-seizure medicines, has the most association with poor outcomes in reference to any exposure at any time in pregnancy, from neural tube defects and teratogenicity to developmental delays across the spectrum. And Risperdal has this study that has recently shown that there may be an increased risk in cardiac malformations. So it's not at the top of the list any longer in making those decisions. So not only for acute stabilization, but lithium and lamotrigine, as well as Tegretol, have also been shown to be effective for long-term maintenance to prevent recurrence. And that's really important in pregnancy. And we have that data for second-generation antipsychotics as well. But the most important pearl here on this slide is that a woman's bipolar illness in the peripartum needs close monitoring. And this is important to have knowledge about, to seek out on your own, because pregnancy affects medication metabolism. The first recommendation is in the two mood stabilizers that are most often used, lithium and lamotrigine, is that you administer them in twice daily dosing to avoid peak concentrations that could generate toxicity in the fetus. Drug level monitoring for lithium and anti-seizure medicine is necessary and is always important to know, and remind patients that the valid drug level is called a trough level, TROUGH, for those of you who are not medical, which means it must be drawn within 12 hours of the last dose, which is typically in the morning after a nighttime dose before she takes the morning dose. Women who end up in the ER due to acute exacerbation of bipolar illness and get a random lithium level are often told that it's toxic or too high, but that level is not clinically relevant. And we often have to reassure women, don't stop or change anything. Let's get that trough level if you're not symptomatic for toxicity. So back to the unique metabolism issues that I think we have to touch on as we get to the end of this. And that is that lithium is metabolized through the kidneys. And in the first trimester, then it increases in the way the kidneys filter, so it can be cleared more rapidly. So it's not necessarily a drug failure or therapeutic failure if symptom emerges when she's on her maintenance dose of lithium in the first trimester. It just means we look at the level, we monitor, and we adjust rather than increase exposure by changing medicines or adding polypharmacy. And this one, I think many of the physicians in the audience may know, but lamotrigine, on the other hand, has a clearance rate that is increased by 330% in the second trimester and early third. So sometimes it requires 3 times the pregnancy maintenance dose of lamotrigine. And then once she delivers, within 2 weeks postpartum, you go back down to the pre-pregnancy level, especially if she's breastfeeding. So remember, for minimizing exposure to medications and illness, it really can be in the fine tuning of drug doses guided by drug level monitoring that allows us to maintain wellness and restore wellness without increasing exposure to worsening of illness, polypharmacy, or changing medicines. And real quick, this Dr. Dorothy Sitt, of the Center for Environmental Wellness, on December 11th, is giving a webinar on bright light therapy for perinatal issues. And I can send the link if y'all need it and want to watch it because it's free. But she has some really good evidence of bright light therapy in major depression in pregnant women with depression. But when it comes to bipolar illness, what we have to do is follow the guidelines. And I'm not going to take time to go over them because they're in the Wisner and Clark paper on your list. And the guidelines are that if you're using bright light therapy as a non-medication strategy for bipolar depression, she must be on an anti-manic mood stabilizer. Because similar to using monotherapy antidepressants in women with bipolar 1, bright light therapy can stimulate a manic episode or a destabilization if she's not covered with something to contain the mania. You can go to the next slide, please. So this slide is not meant to be followed specifically, but to show you some examples of what studies have been done in what is we call prophylaxis, or of prevention, sort of jumping ahead of the curve, really, is how we might say it. And I'm going to hit the highlights as we wrap up and refer you to the article by Dr. Bergink in the references. So some of the studies we have, one that's really old, is that in lithium-responsive women with a history of postpartum psychosis only, which is usually a bipolar spectrum illness, who have been successful in tapering off medicine in pregnancy, there is evidence that starting lithium 6 weeks prior to delivery can translate into a decreased recurrence risk. In a study by Dr. Adele Vergara, she also noted that if you start that lithium, or if a woman's on lithium in pregnancy, that if it is withheld 24 to 48 hours prior to delivery, it decreases the risk of the baby having negative side effects, such as something called floppy baby syndrome, thyroid, or kidney problems. And planning with MFM and OB is essential to do this, and sometimes even scheduling delivery. But withholding it for that short time protects the baby and did not increase the risk of exacerbation of illness in mother if it started immediately, again, postpartum. So Dr. Bergink, who has done most of the prevention studies, all of which support protected sleep immediately postpartum as a preventive strategy for bipolar illness, can also influence remission. And I think I have about 3 minutes, and I think we can do it. In bipolar 1 illness in particular, it's recommended to promote sleep with lorazepam within the first 3 nights postpartum. Of course, this is challenging because women are neurologically and psychologically driven to have a strong desire to wake up with their babies and care for them, and they expect to be sleep deprived. So this strategy really need psychoeducation planning and support with mother and family and everybody. And using mood stabilizers, atypical antipsychotics such as olanzapine or Seroquel to promote sleep early on is something most women protest because they know if they have bipolar illness how sedating they are, and they fear that if necessary to wake up with their baby or to wake up if someone's caring for their baby because they need them, then they won't be able to. So lorazepam is really favorable and it works well, and it's also compatible with breastfeeding. Other concerns about this are that they won't be able to breastfeed their baby at night. And that's kind of sometimes a given in bipolar illness as a preventative strategy to protect sleep as well as medication. So a discussion about flexibility with breastfeeding to protect sleep and to minimize exposure to bedtime medications in the first 2 weeks when the baby's liver isn't fully developed. I encourage women to not see breastfeeding as an all or nothing phenomenon, as something very fluid and flexible, and to be confident in that flexibility, that it's sometimes necessary to supplement with formula so they can sleep, but you can go back to the breast in the daytime and you can be flexible and work with that. And that's actually a treatment recommendation in postpartum depression as well. In a recent op-ed that was published about just using sleep as a treatment for postpartum depression. So a last in 1 minute word about breastfeeding. It's safe with lamotrigine and with atypical antipsychotics, but the baby has to be monitored for sleep. It can be safe with lithium, but it's pretty darn complicated. And I've only done it 3 times in 30 years, and it's beyond the scope. But there's, again, Dr. Adele Viguera has a good article for how to do that. But think about it, the mother has to be pretty stable because the baby has to be monitored by the pediatrician for lithium levels and kidney and thyroid function. ECT is an option that what I recommend is that in the planning process, you identify an ECT provider who's going to be willing to do ECT in pregnancy or postpartum as part of the process, or it's not on the table if you don't have a provider that's willing to do it. Next slide, please. So these are some important highlights specific to postpartum psychosis, but I think can be generalized to bipolar illness. Always, 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 in severe psychiatric illness in the postpartum, check not only thyroid function tests, but thyroid peroxidase antibody. There's a strong association with autoimmune thyroid disease and severe postpartum psychiatric illness that, if not treated concomitantly with the psychiatric illness, will be an obstacle to recovery and remission. And there's a new article out recently that across the board, autoimmune conditions are certainly associated with perinatal psychiatric illness, particularly in the postpartum, and that's worth looking at. And lastly, because I think I'm down to my last minute, I think we should mention real quickly, if I can get half a minute, Zulresso and zuranolone. You know what those are, right? Brexanolone and zuranolone, or Zulresso and Zurzuvae, sorry, the trade name Zulresso and Zurzuvae. That's the synthetic form of allopregnanolone, which is a hormonal treatment that's been approved for moderate to severe postpartum depression. Now, it's not been studied in or approved for bipolar illness, but there are some ongoing studies for bipolar depression. And because it's a GABA enhancer, that means it's very calming. And because in case reports it has been used, it can be effective in some bipolar illness syndromes. The problem is cost prohibitiveness. You'd never get it approved because it's not FDA approved for that. If you want to look further into it, the by-mouth preparation, which has been approved and is now available, is a 14-day treatment course. You usually see response by day 3, and you still keep the psychiatric medicines on board. So if you use it for bipolar illness, you would do that as well. You did it.
Great job, Dr. Bruto. And thank you, Dr. Finelli, for putting some of the article links in the chat too. Some of them are in the chat, and then some of them are on the reference slide, just so everybody knows. We're gonna hold questions to the very, very end for now, but thank you so much.
Thank you, everyone. I really appreciate it.
And thank you, Dr. Bruno, for the presentation. It was great.
Thank you for the opportunity.
Like Dr. Olivier said, we'll send out an email that has the slides attached from Dr. Bruno's presentation, the recommendations, and then the links that are in the chat. And then it also will have the survey link that you can fill out to give your feedback for not only this session, but for planning for the next cohort, which starts in February. And so we just really appreciate your time and thank you for participating in this cohort. And we look forward to seeing everyone in February. Have a good rest of your day.